Hey there, it's Dr. Suchard again. This time the topic of discussion is going to be sodium bicarbonate, which I'm sometimes just going to be referring to as bicarb. And this content correlates with Chapter A5 from the Antidotes in Depth series in Goldfrank's Toxicologic Emergencies. The learning objectives for this video are that once you've studied the related materials, you should be able to list at least 2 toxicologic indications for using sodium bicarbonate, and you should be able to outline recommended antidotal bicarb dosing regimens. First off, you should know that sodium bicarbonate is a non-specific antidote, in that it's not indicated for just one kind of toxic effect or toxicity from just one class of poisons. The more common antidotal uses for bicarb are listed here, which are to treat salicylate toxicity and also to treat the cardiotoxicity manifesting from sodium channel blockade, which I've represented here with the core chemical structure of tricyclic antidepressants, the classic example of a sodium channel blocker seen in overdose situations. But bicarb also has antidotal roles in treating a longer list of drugs and poisons, with some of the mechanisms being more specific and some less specific. As just alluded to, bicarb has different mechanisms of action depending on what poison for which it's being used as an antidote. On the left-hand side, I've listed the more important mechanisms, since they're the ones related to salicylate toxicity and for sodium channel blockade. Starting from the top left, sodium bicarb alters the interaction of the xenobiotic with the sodium channel that they're blocking. And with salicylate toxicity, bicarb has 2 effects relating to alkalinization, pharmacologically manipulating the pH of body fluid compartments. Sodium bicarbonate alters salicylate ionization that both affects its distribution in the body and enhances its renal elimination. And on the right-hand side, we see several other mechanisms. Bicarb may correct life-threatening acidemia in selected tox cases. Changing the pH can also affect drug solubility or neutralize acids released by exposure to some xenobiotics. Some non-tox-specific mechanisms, like renal protection from rhabdomyolysis and potassium shifting to treat hyperkalemia, will also work in tox cases when these complications, which are not rare, have occurred. Starting on this slide, we're going to be looking at cardiotoxicity from fast sodium channel blockade using the example of tricyclic antidepressants, or TCAs. So you'll recognize the graph on the top as the cardiac action potential, and the lower graph as the corresponding EKG tracing. The black lines here are the normal state in the absence of sodium channel blockade. We see that normally the depolarization in phase 0 is very rapid. Sodium is rushing into cells along its electrochemical gradient through the voltage-gated sodium channels, and this corresponds on the EKG to a fast or narrow QRS complex. But in the presence of sodium channel blockers, the influx of sodium is impaired, decreasing the slope of phase 0 in individual cardiac cells and manifesting on the EKG as a widening of the QRS complex. Now, if we want to consider the spectrum of cardiac effects we'll see with increasing TCA toxicity, the first thing we'll see will be a sinus tachycardia from their antimuscarinic effects, counteracting the normal amount of vagal tone on the cardiac pacemaker. Then, as the amount of sodium channel blockade increases, the QRS will widen. And if it widens far enough, the patient can develop ventricular tachycardia or even worse rhythms. But since these changes occur along a spectrum, we may be able to detect sodium channel blockade and start to treat it before malignant arrhythmias develop. And this is why getting an EKG is a good idea in an overdose patient, looking for, among other things, evidence of sodium channel blockade that you probably wouldn't detect any other way. This slide shows the EKG changes seen with sodium channel blockade. This particular EKG is from a patient I saw who overdosed on diphenhydramine, an over-the-counter antihistamine, but which causes sodium channel blockade at higher doses. And we see QRS widening. The QRS duration here is 120 milliseconds, with normal being 80 to 100 milliseconds. And there's an atypical morphology of the QRS complex that's best seen in lead AVR, which is usually the least informative lead on a standard 12-lead EKG. Normally, all of the deflections from the isoelectric line in AVR are downward, but here there's a significant portion, the latter portion of the QRS complex, that appears above the isoelectric line. This morphology has been described in several ways, but they're all describing the same phenomenon. With sodium channel blockade, the right bundle tends to be blocked more than the left, so the depolarization toward the right is more delayed. Normally, the right and left sides of the heart depolarize at the same time, and since the muscle mass of the left is so much larger, we never see the rightward depolarization on a surface EKG. But in the presence of sodium channel blockers, the left side depolarizes first, and if there's enough delay in right-sided depolarization, we'll now be able to see it occur immediately afterward. And AVR is the lead where this is best observed, since it's a lead over the right side of the heart, AVR for right. This sodium channel blockade can be treated with hypertonic sodium bicarbonate, and there are two independent mechanisms for this. The first mechanism relates to the sodium. The bicarb solution we're giving is hypertonic, increasing the serum sodium concentration. This increases the chemical gradient of sodium across the cell membranes, favoring sodium influx during depolarization, so, in effect, overcoming some of the sodium channel blockade. It would be possible, for instance, to simply give hypertonic sodium chloride to help overcome the sodium channel blockade by the same mechanism. But using sodium bicarbonate allows us to also use another mechanism. The binding of sodium channel blocking drugs to the sodium channels is pH dependent, and they tend to bind better at a lower serum pH. Giving bicarbonate, a base, increases the pH to decrease binding to and blocking of the sodium channels. And here again, it would be possible to use a different pH buffering agent than sodium bicarb to raise the pH, but why not use sodium bicarb to take advantage of both of its mechanisms at the same time? Here's a slide only slightly modified from my salicylate presentation, showing how bicarb works in treating salicylate toxicity. Alkalinization of the serum increases the relative amount of salicylate found as the charged ion, which is then less absorbed from the circulation into other body tissues. And the exogenous bicarb will also alkalinize the urine, ion trapping the salicylate in the urine and enhancing renal elimination. How is sodium bicarbonate dosed when used as an antidote? We're going to start with bicarb used for sodium channel blockade, which will be when the QRS duration on the EKG is greater than 100 milliseconds when it's not known to be a pre-existing condition. The regimen recommended in the Goldfrank chapter is to start with 1 to 2 milliequivalent per kilogram IV boluses of sodium bicarbonate, repeated to reach a goal serum pH of 7.5 to 7.55. Then you start a continuous infusion of bicarb, made by adding 3 50 ml ampules of 8.4% sodium bicarbonate to a liter of D5W, and run this at twice the maintenance fluid rate, so roughly 150 to 200 mL per hour in adults. And the reason for it being 3 ampules of bicarb per liter is because the resulting solution will be roughly eunatremic with serum. 8.4% bicarb, which is the most common standard concentration, is the same as 1 milliequivalent per milliliter, such that adding 150 mils makes the solution have 150 milliequivalents per liter of sodium. And while the bicarb is being given, the patient is going to get frequent EKGs to check on the QRS duration, as well as the serum pH and potassium concentrations. The dosing regimen for bicarb used to treat salicylate toxicity is essentially the same. The patient is given IV bicarb boluses of 1 to 2 milliequivalents per kilogram, with a pH goal now in the 7.45 to 7.55 range, followed by continuous infusion of the same 3 amps of bicarb and a liter of D5W solution. And the patient is also monitored, but now there's an additional goal of ensuring urinary alkalinization with a goal urine pH of 8. In practice, these patients will usually have an acidic urine pH for a while after alkalinization therapy is started. And you'll check it multiple times, not seeing it budge very much if at all, and then suddenly some threshold will be passed, and urine pH suddenly shoots up to alkaline, and you breathe a sigh of relief. In the previous 2 slides, we talked about adding 3 amps of bicarb to a liter of D5W to create a roughly eunatremic solution. I've also seen people use D5 half normal saline with 2 amps of bicarb and additional potassium, say 40 milliequivalents added per liter. This solution is higher in sodium than serum, although not an extreme amount higher, and it works on the reliable prediction that you're almost definitely going to need to supplement potassium anyway. I like to consider that systemic alkalinization is metabolically invasive therapy, to remind myself that these patients are going to need close monitoring clinically and by serial lab results. And the word metabolic here is actually a bit of a misnomer. It's not biotransformation, but it's just as metabolic as, say, the basic metabolic panel lab test is. If you're not careful with bicarbonate therapy, you may cause excessive alkalemia, hypernatremia, fluid overload, hypocalcemia, and especially hypokalemia. As we know, H plus K plus exchange happens in the body such that alkalinization with bicarb will shift the potassium intracellularly. And if you have a patient on a bicarb drip, you're virtually guaranteed to need to supplement potassium. It's mostly an issue of when you'll need to start it and how much you'll need to give. All right, that's the presentation about sodium bicarbonate as an antidote. I'll be seeing you around.